So I have to say this is my first time lecturing in a library, so I was told I do not have a microphone, so it's natural for me to speak very loudly anyway. So, but it is kind of weird to be speaking so loudly in a library. So as Dan introduced, I'm Dr. Allison Muller. I am a pharmacist by licensure and a toxicologist by board certification. Just to give a 30-second background of myself, I have been with the Poison Control Center at Children's Hospital of Philadelphia for the first almost 20 years of my career. Then I went on to work in medical education for physicians, mostly in the field of oncology. And now I have my own consulting business, so I do a hybrid of the two. I, of course, do toxicology consults for attorneys, and I also do medical education still for oncologists. So even though toxicology is my passion, and I can talk about toxicology all day, do not worry, I'm going to be very respectful of your time. We'll be done by 6:30. If there are questions to go over, I'll be happy to give my contact information, although you have it in the PowerPoint presentation. I gave you a business card, and we can talk about maybe a case that you have, short conversation about that. So that being said, let's start with Toxicology 101. So just to give a lay of the land, expected effects on the body from some common street drugs, common prescription drugs, and how I take these are common as far as I'm concerned, as far as questions that I've gotten about cases, or just in terms of how frequently they're encountered in cases. And when I talk about drugs, I also refer to alcohol because it technically is a drug as well. You'll get these piles and piles of medical records, including laboratory analyses, and you'll kind of wonder, drug and alcohol levels, what do they mean? How do I interpret them? I have some levels from the blood, I have some levels from serum, I have some levels from urine, from breath, which is reliable, which isn't. These are things that you, as attorneys, can kind of sort out even before you call an expert toxicologist. Some false positives and false negatives. That's always interesting because sometimes these lab results are not really what they seem on both sides of the spectrum, positive and negative. Utility of these drug levels. I get questions a lot, especially with impairment cases. I have this drug level. Does this equal impairment? Does this indicate how a person should have been able to safely drive or safely operate machinery? And then finally, specifically, drug and alcohol levels and how we're going to interpret them. So just some definitions. I mean, I could go on and on about different definitions in the field of toxicology and in pharmacology, but there's some basic ones that I think as attorneys you should know, just in either doing your own research about cases related to drugs and alcohol, but also interacting with experts. So we'll first start with metabolite. So after a drug breaks down, so a drug is taken into the body and it breaks down into metabolites. And metabolites might be more potent than the actual drug that you started with, or a little bit less potent, or completely inactivated. So why that's important is because you'll get drug levels and it might not say the drug that was actually taken, it might say something that you're not really familiar with. And that's more than likely a metabolite of that drug. And sometimes it's easier to measure a breakdown product of a drug than actually the drug itself. And how a drug is metabolized, meaning how a drug breaks down in the body, is going to vary from person to person based on maybe what other drugs they're taking or what their own genetic predispositions are. There's more and more data out there in terms of certain genetic conditions, and I don't mean disorders, I mean conditions. Some people have pathways in their body that break down drugs easier than others. And then next is detection time. So this is a common question that I get not only in the legal realm but also in the medical realm. How long does it take before a drug is no longer detectable on a toxicology screen? And it's going to vary with the amount of drug, of course the type of drug, but the amount of drug, how often that person is using that particular drug. But in general, if it's something that is an acute exposure to drug, meaning like a once in a while, one-time deal, usually it's gone within a week. The most that you are going to see a detection time play out is about 30 days. So even if it's somebody who's been using marijuana day after day after day, if they stop and they've been a non-user, in 30 days they will not be tripping a toxicology screen as positive. And finally, route of administration. Route of administration is how a drug gets into the body. So the most common route of administration that we hear about, because it's the most convenient for patients, is the oral route. Now the trick is with the oral route is that the drug will have to pass through circulation through the liver. Now the liver, think of it as a big filter. So it's breaking down drugs, it's filtering out toxins, it's forming metabolites. But the key is if it's being taken orally, it definitely is broken down sometimes to the point where it's not potent enough. Like for instance, a drug like insulin. Why don't diabetic patients take insulin by mouth? It would be so much easier, so less painful, that sort of thing. Because by the time it makes its liver, it's broken down and it's inactivated. So this is just some basic definitions. Now for the good stuff. I think I took 3 semesters between undergraduate and graduate school of pharmacokinetics, and I can try and block those 3 semesters out of my mind at some point because it's very labor intensive learning pharmacokinetics. There's equation after equation after equation that you memorize, but I have distilled it down for you into 4 basic principles of pharmacokinetics. So first, what is pharmacokinetics? Just quite simply, pharmacokinetics is what the body does to a drug. And we're going to see something called pharmacodynamics in a few slides. So pharmacokinetics is what the body does to a drug. And so after we go through these 4 principles of pharmacokinetics, you'll see why it's interesting and potentially helpful for you to understand what pharmacokinetics means. So absorption is the time that it takes for a drug to be absorbed into the bloodstream, whatever route of administration it is, oral, IV, ocular, whatever the case may be. But it's going to, the time for absorption is going to vary with that route of administration, but also the amount of the drug that's taken. Now, again, I refer to alcohol as a drug, because it actually is a drug. And what interferes with time of absorption for alcohol? The first thing that comes to your mind probably is food, and that would be accurate. Food in the stomach slows the rate of alcohol absorption. Now, what it doesn't do is it doesn't change how high the alcohol level is going to be at the end of the scope. It's going to be just delayed. So in general, you get a peak alcohol level somewhere around 30 minutes to 60 minutes after the last drink is consumed. But if you have a full stomach, then that delay in absorption is going to be longer. So you're going to have maybe even after an hour before you've reached your peak level. That's what's challenging as an expert sometimes, especially if I'm only given one alcohol level to try and look retrospectively what alcohol levels were prior to a given point in time. Because I don't know if I only have one level, I don't know if that peak has been reached yet. And when I show you a short but simple graph about pharmacokinetics, you'll see why that is important. The second principle of pharmacokinetics is distribution. So the distribution is once the drug gets into the body, goes into the bloodstream, and then it goes all around the body. So it's distributing to all tissues. So this is good and this is bad because, drugs are meant for certain disease states, for certain conditions, for certain pains. If I have pain in my arm, why is this drug going all over to my body? Because that's the way drugs work. They distribute all over. Now, that leads to, of course, problems with toxicity. But now, with the case of alcohol, is that alcohol will move from areas of high concentration of water to low concentration of water. And there's the distinguishing factor between men and women. Unfortunately, women have more body fat and less water than men. So what does that mean? Well, if I have one drink and then a gentleman next to me has the same exact drink, who's going to have the higher alcohol level? I am, because I have more fat and less water, and he has more water and less fat. So his water is diluting out the alcohol. He will have a lower level. Metabolism, we already had a hint about what metabolism is because we talked about metabolites. And so metabolism is simply the breakdown of a drug by the liver, and it's one of the steps for eliminating a drug from the body. And again, the significance of metabolism is knowing that you're going to often be looking at laboratory results for drugs that are metabolites, not the actual parent drug itself. Now the next slide covers elimination, and this is what I meant when I talked a little bit about I only have a single alcohol level in time and I want to know one, retrospectively. So there is first order versus zero order kinetics. Now this is a complicated principle of pharmacokinetics, but I think it's of interest to attorneys for the reasons of trying to establish different points in time for a drug level. So alcohol is eliminated from the body by zero order kinetics. So you see the zero order kinetic line in the graph is a straight line. So you can see that if you have one level, you can, with some accuracy, you're not going to get a pinpoint, you at least get a range. You can go backwards on the line and you can say, all right, now I know if I'm going backwards in time, I'm going to have a concentration as a straight line. But most drugs undergo a different type of elimination. So zero order elimination means the more and more alcohol that is put into the body does not adjust how quickly it is eliminated. It's a fixed rate. Whereas with drugs, the more and more drug that's put into the body, that rate is adapted to the amount of drug in the body. So that's known as first order or nonlinear. That's why you don't have a line there for concentration versus time graph for zero order kinetics. And so that makes extrapolation of drugs very difficult, and to the point where you don't really have a good scientific grasp of how to do that. So there's some degree of accuracy with interpreting an alcohol level and looking at different points in time because you have a straight line, concentration versus time graph. But if you ask me, hey, I have this drug level, and what was it 4 hours ago, I'm not going to be able to tell you what that is, because there's a lot of variables when it comes to the kinetics of drugs, and the simplest way to explain it is that they go through first order kinetics. So this was the other principle that I alluded to when we started talking about pharmacokinetics. This is pharmacodynamics. So pharmacokinetics is what the body does to a drug. Pharmacodynamics is what a drug does to the body. So there's many over-the-counter, illicit, prescription drugs that can impair a person's ability to drive. And you see when you go to the pharmacy, there'll be these what we call auxiliary labels on the side of the bottle, or even over-the-counter medications that say, use caution when driving or operating machinery. Now, not every drug has been studied in terms of a relation to cause impairment per se, but we know what drugs can do in terms of, do they cause drowsiness, do they cause dizziness, do they cause blurred vision, do they cause memory issues, do they cause judgment imperceptions, what exactly do they do? So we have those bits of data. What we don't have on drugs, and I'll be repeating this several times within the presentation, what we don't have on many drugs is what levels correlate to a degree of impairment and what amount is safe to take. And so for pharmacodynamics, what a drug does to the body, we know from a basic scientific standpoint what the drug would be expected to do, but we don't necessarily have levels to tie that. Now, on the line of levels, this is definitely a very important factor in looking at anything any paperwork you have that's reporting drug levels. And I stress this with students as well, medical students, and I also teach veterinary students. So they'll come to me with this level, and they'll say, okay, the level was 18 for sake of a number. Okay, tell me about that level. That's all they say is it's 18, whether it be a drug level or heavy metal level, whatever level they're giving me, and they say, well, it's normal, it's WNL. So to them, WNL means within normal limits. To me, WNL means we never looked, because it's very important to have units. I had a case, this was not a drug-related case, this was a heavy metal case, where I had two clients that were at the same industrial site. They saw two completely unrelated physicians, not in the same practice, not in the same medical center, and they were both taken off the job because they both had this particular level done for a heavy metal, and they said it was toxic, and it reported to me by the attorney as 80. This would be really cool if this really was this heavy metal toxicity. I don't hear about this metal every day or even every year. So I said, send me the records. Let me even take a look to see if this is a viable case. So I get the records. It's not 80, because I'm thinking 80. He hasn't told me units. It's more like 0.8. I probably have a higher heavy metal level than these people do, and they're working with this stuff every day. So it's very important that you would have the units. And I mean, on a laboratory report, you're getting something from, National Medical Services. I mean, you're getting something from a bona fide laboratory. They're going to have units there. matter. But the important thing is to communicate the units if you're having a discussion with an expert. And also, if you're doing some research yourself, which you probably will be doing, you want to make sure that you're comparing apples to apples. So when you're seeing 80, is it really 0.8? You know, what exactly are the units of measurement? Because it could be 10-fold, 100-fold different than what you're comparing it to. So toxicology testing is an interesting science in itself because there's several different types of body fluids that are used to do toxicology testing, and there's different categories of toxicology testing. We're just going to talk about pre-mortem testing, meaning testing done in patients that are alive. Of course, patients that I'm consulted on that have already died and are getting drug levels done, that's a completely different area, and there's many more types of body fluids like eyeball fluid and liver blood and that kind of thing that we test in patients that have died. But for purposes here, we're going to talk about urine, blood, hair, breath, and saliva. So which one is the most accurate, and which one are you always looking for? Well, hands down, blood is the most accurate for sure. The downside of getting blood levels as opposed to urine levels is there's a shorter detection time in blood than in urine. So a blood sample is more likely to tell you about recent use versus a urine sample. Now, that being said, the problem with urine samples, I'll give you pros and cons. So urine samples do have a longer detection time for many drugs and for their metabolites. But again, I mean, urine levels, even blood levels, they don't tell you a lot on their own other than the drug was used at some time. Like the question I get a lot is about marijuana levels. So THC is one of the active metabolites that's screened for following marijuana use, and they'll get the question of, this was the level of THC. Was this person high at the time of fill in the blank here? The accident, the workplace incident, blah, blah. And it's very hard to tie a time to a level, especially something like marijuana. Marijuana stores very nicely in body fat. And so that being said, it releases over a gradual time frame. So you really can't say that this person with a level of 200 was impaired, but this person with a level of 50 was not impaired. Those kind of data just does not exist. So when we say a urine drug screen, so I'm going to make the distinction between a urine drug screen or a confirmatory test. So when a patient goes to emergency department, whether they're there for an overdose, whether they are following impairment or a car accident, they get something called a urine drug screen, which tests for the most common drugs of abuse. And depending on this screen, now again, a screen is just telling you one thing, who needs to get further testing, just like any other kind of screen. Like if you're getting a cancer screen is not telling the patient they have cancer, it's saying this patient needs to get more testing, that's all that's saying. So urine drug screens test for anywhere between 6, 8, 10 drugs of abuse, and it's testing for often metabolites, and so it's not able to test for every drug in every class, and I'll go through more detail of that when we talk about false positives and false negatives. Then there's confirmatory tests. So the most common confirmatory tests, you'll see the abbreviation GC, which is gas chromatography, or MS, which is mass spectrometry. Those are the molecular fingerprints of drugs. So that there is no mistaking if you have a GC MS result on a drug screen. There's no false positives, there's no false negatives. Urine drug screens, however, like I said, are testing for metabolites. There's a lot of cross-reactivity between the different classes of drugs at times. So they are simply a screen. But I'll give you a preview. It doesn't matter what test it is, there are no false positives for cocaine. There's a lot of false positives for other stuff, but not for cocaine. So a word about, I skipped right over hair and breath and saliva. So, I mean, there's tests now that you can even have over the counter. I mean, you can go to your local pharmacy and buy, hair testing kits or saliva testing kits for, for drug screens type of thing. The interesting thing with hair is, again, it's not giving you a level that necessarily tells you when the drug was used. And because with hair, the drug stays in the hair for up to 3 months after exposure and, until the hair is cut. So it's just telling you if the patient has ever used the drug in question or not. It doesn't tell you if the patient used it yesterday or 3 months ago. The problem with hair is there can be surface contamination. So, you know, if I'm in a room when somebody's smoking crack, somebody tests my hair, I'm most likely going to come up positive for cocaine. Now, just an aside about that kind of, you know, effect of, I've gotten this question before, you know, the Grateful Dead concert effect, as one of my colleagues likes to say. Would I come up positive if I was in a room with a whole bunch of people smoking marijuana, but I didn't smoke it myself? The answer is no, you would not. Would I have marijuana in my bloodstream? Yeah, but not enough to trip a drug screen, and that's why there's something called cutoff values. So this way it avoids that kind of false positive thing. Now they did a study in at Johns Hopkins with this sort of thing, but under very extreme conditions with this kind of Grateful Dead concert effect, where it was a very small room where pretty much you couldn't even see through the, you know, the air in the room because there was so much marijuana smoke. Those patients came up positive for marijuana, but it was a controlled condition, so it's definitely not translatable necessarily into, you know, everyday life type thing. And then finally, breath tests. I mean, we have great data on breath tests for alcohol, as you know, and it's a popular and accepted method for testing. We're not there yet with drugs. We're still investigating that method for drugs. And when I get questions from attorneys about breathalyzers, I know what a breathalyzer is, but I don't know how to work one. I don't know what the, you know, the different brands are, how you calibrate, that kind of thing. And you may have this experience already. There are experts that what they do day in and day out is they are able to dissect the results from breathalyzer tests, and they understand these machines. So that would definitely be your referral on my end. And then finally, saliva. The saliva tests, we're not quite there yet with a lot of drugs that we can use data from saliva levels, but we're getting there. So I mentioned that, you know, we don't want to take drug levels in isolation. What I do as a toxicologist is I will certainly look at the drug levels, look at them closely, and make sure I see the right units. But I also want to see what are the reports of a bystander, if it's like an accident, for example, an impairment case. I want to know how the patient, or, see, I say patient because I come from clinical medicine, so you're thinking, it's more like client. What is the client's demeanor? What was their you know, reason for being pulled over at the traffic stop, that sort of thing. And so I want to know symptoms, and I also want to know behavior, so I want to know some details. But I also want to know medical information on the patient too, because this can make a big difference. I want to know what medications does this person take on a regular basis. I want to know everything. I want to know prescription, I want to know over-the-counter, and I even want to know those herbal medications, because people say, well, I didn't mention those to anybody because they're natural or they're herbal. Well, that's being said, I mean, digoxin is natural, cyanide is natural. I mean, a lot of things are natural that really have some very potent effects in the body, so I want to know about herbal medications too. And why do I want to know about this whole medical picture of people? Because there's definitely drugs, you know, all types of drugs that could affect how the person responds to a certain amount of alcohol or other drugs that are on board. So that is definitely of interest to me as an expert. So what can drug levels tell you? Well, I alluded to this already a few times. So let's say you get a positive result for a drug. That tells you that some point in time this person used the drug, maybe. The key word is maybe, because there are definitely false positives. Now, that being said, that's in the screening test. That's the first step. And do all medical records have both types of testing, the screening test and the confirmatory tests? Unfortunately, no. So then there's a lot of questions surrounding the results if all you have are urine or blood screening results from a toxicology screen, not the actual confirmatory test. And what can drug levels not tell you? Well, it cannot pinpoint the dose of the drug that was taken, whether it be a legal or an illegal drug. It can't tell you when the drug was taken. Sometimes you can make, you know, somewhat of an educated guess based on, you know, patient-specific information and based on pharmacokinetics, but still you're not going to really nail it down of how much was taken, exactly when it was taken. And with the exception of alcohol, there's no widely accepted correlation between all these drug levels that we like to get and a corresponding level of impairment. And finally, there's no test that's going to pick up every drug. And we keep seeing this because there'll be like the amphetamine du jour that is now out on the street, and it's not being picked up when these patients come to the emergency department on urine drug space. And wait a second, but they even said that they were taking an amphetamine. Yeah, but that's a new one. It's not picked up on the screen. It's not, the metabolites is not being picked up on the screen. So for alcohol, even alcohol, the behavior and the level of impairment is going to vary from person to person for a given level, because it depends, especially if the patient is, alcohol naive, drinks once a year, drinks, a couple times a year, whereas somebody else who drinks more frequently, they're going to have a different reaction to the same exact level. I've gotten the question about substances that can falsely elevate breath alcohol levels. I mean, they certainly exist. I mean, because the alcohol screen for a breathalyzer is looking for ethanol, but there's some things that may cross-react. And again, there's experts out there that can tell you these things in regards of this type of breathalyzer used or that type of breathalyzer used. But some of the breathalyzers are not specific enough to ethanol, which is what alcohol is, beverage alcohol. But it might pick up falsely if there is a gasoline fumes or certain medical conditions. Medications or drugs or anything else, however, is not going to change a blood alcohol level per se. All right, we'll start with false negatives before we move on to false positives. False positives are more interesting, but we'll start with the false negatives. So the top 3 false negatives, meaning a patient comes up positive for these on a drug screen, but or does not come up positive for these on a drug screen, but admits to using these drugs, either legally or illegally. So the first one is benzodiazepines. So benzodiazepines are things like Valium or Xanax or Ativan, used for sleep, used for anxiety, used in surgical settings. And so the reason why sometimes patients who are on these medications don't come up positive is because the particular benzodiazepine that they're on is not being broken down into the metabolites that particular drug screen is looking for. Now, if they're getting confirmatory tests, that's a whole different story. But what we are seeing most often is just the urine drug screen. That's what you're always starting with. Same thing with opiates. I had a case where the attorney had asked me, now wait a second, this patient is on oxycodone, but came up negative on the opiate screen. So opiates and opioids, for our intents and purposes, are interchangeable terms, by the way. Well, they came up negative because that particular test that they were using for that person was not going to pick up that type of opioid. So that's why they were not coming up positive. And then amphetamines is it's a very tricky drug class because there's false negatives for amphetamines and false positives. So often the amphetamine screen misses some of these, fancy amphetamine street drugs that are out there now, like things like ecstasy or Molly. But as these new types of designer amphetamines come out on the street, I almost said out on the market, but I guess it is market, come out on the street, then the drug screens are sometimes updated to then catch those additional types of drugs. False positives. That's what I mostly get questions on, is false positives, as you can probably imagine why. Back to amphetamine. So depending on the test used, somebody might get a false positive for an amphetamine. They've never taken an amphetamine in their life. But some cold medications will trip a screen for amphetamine. So that Sudafed that I took last night for my stuffy nose, on some screens would make me positive for an amphetamine. So then what do I do? Well, if there's any question, again, you have a screening test, there's confirmatory tests, and hopefully that's done. Some antidepressants, some anti-ulcer medications also cause false positives for amphetamine. So big class of drugs where there's false positives. False positives for morphine and for codeine. So these two cross-react with other types of opioids for sure. So morphine is a natural, the natural product is derived from the poppy plant, right? Poppy plant exists in nature. And I know what you're thinking, what about that poppy seed bagel that I ate this morning? So could that cause a false positive for morphine? It certainly could, but the trick is it's the dose makes the test here, because one poppy seed bagel, remember there's a cutoff for these tests, so to avoid false positives, so it's high enough that it's not going to pick up, the 50 poppy seeds that I ate this morning. You eat maybe, 60 poppy seed bagels, well then we're talking, then you might get a false positive, but it really is a true positive because it's from the poppy plant. Phencyclidine, which is angel dust or PCP, we don't hear a lot about this drug as much anymore. I mean, it's still available, it's just not as popular. There's many false positives for phencyclidine. Another cold medication, so I mentioned, pseudoephedrine, one of the Sudafed products causes some tests to show a false positive for amphetamines. Well, the dextromethorphan that's in a product, like Robitussin DM or any cough syrups ending in DM, that can cause a false positive for phencyclidine. Even the pain reliever ibuprofen can cause a false positive for phencyclidine. So those are, safe, effective, legal drugs that are causing false positives for, some pretty scary classes here. So we'll go over some common drug classes, and I told you how I came up with what I thought were the most common ones, which ones would be of interest to you, which ones are going to cross your paths, and many but not all of these drugs negatively affect driving ability. But even if they don't on their own affect driving ability, they have the potential, and we'll go over them each individually, they have the potential for affecting driving ability with even a legal amount of alcohol. So starting with benzodiazepines, so I gave you some examples, your Xanax, your Ativan, and your Valium. So what do they do? Well, they're supposed to relax the nervous system, which is a good thing if you're treating insomnia or you're treating anxiety or you're getting ready for surgery and getting the rest of the anesthesia. But what do they do to the driver? And keep in mind too, like you'll see these auxiliary labels on prescriptions that say, do not drive, do not operate heavy machinery, this, that, other thing. And what are they supposed to, patients that are on these drugs can never drive again? No, of course not, that would be silly. But what they're trying to relate to patients with those is make sure you know how you're going to react to these. Don't go and drive the next day, after starting one of these drugs. See how you're going to react to it. They do develop a tolerance to it at some point, but also to see what your cognition is. I mean, you have to put a little bit on the patient on this. So for benzodiazepines, they do interact with alcohol, and the simplest way to explain why they interact with alcohol is because they have additive effects. So if you have a drug that causes drowsiness and you have alcohol that causes drowsiness, you put the two of them together, you're going to have even more drowsiness. So that's the simplest way to explain that. Sometimes the benzodiazepines are detectable on a drug screen. As we said, there's some false negatives for benzodiazepines, less likely some false positives, but certainly there. And I'll give you a hint to the question that I'm going to ask on every one of these slides. Are levels useful? And the answer for every one of these is no. Opiates or opioids, again, we'll use those interchangeably. No need to go into the pharmacology, the difference between the two for our intents and purposes. So what do they do? Well, we know in general they're used for pain, right? That's a big thing in the news today. And the CDC has made recommendations in terms of what's the way to treat chronic non-cancer pain. Should we be using opiates in patients right off the bat? Should we be using the long-acting? Are they safe? Should we have naloxone in every kitchen? Like, what should we do? So there's a lot of controversy about opiates, but I digress. So they're used not only for pain relief, but cough suppression. So codeine is an opiate, and it's used on a prescription basis for cough suppression. So there's really inconsistent evidence out there. When I say evidence, I mean, in the scientific literature, as to whether opioids and opiates produce any kind of psychomotor impairment. It really depends on the type of opioid, how it's used, what's the route of administration, and sometimes the tolerance too. They definitely interact with alcohol. Again, opiates are downers, to simplify it, right? So you have a downer like alcohol, that makes the patient even more drowsy. There's definitely false positives and false negatives for these. Some are easily detectable on a tox screen, some are not. And I don't have to tell you the answer to the last question, levels useful now. Antidepressants. So there's several classes of antidepressants. Antidepressants are a very complex class of drugs for the very reason that antidepressants are changing the neurotransmitters, messing with the pathways in the brain. That sounds like a very complicated and potentially dangerous situation, but antidepressants are tested, in certain doses to be safe and to be effective, but certainly they don't always do exactly what they're supposed to do, and there's going to be side effects like with any other type of drug. So, for example, a patient will get something like Prozac. It's a newer or somewhat newer class of antidepressants known as selective serotonin reuptake inhibitors. Much safer antidepressants than the ones that came out in the 50s, but they do interact with alcohol and they can intensify the effect of alcohol in terms of impairment. Sometimes they are detectable on a tox screen, the different antidepressants. I mentioned some of the antidepressants that can cause false positives for things like PCP or things like amphetamines. But antidepressants and alcohol do not mix for a couple reasons. One of which, if you are treating a depressed patient, they should be avoiding alcohol because they have depression to begin with, and then using another depressant drug like alcohol can be problematic. But also because of the impairment, and for simplicity's sake, antidepressants are doing things in the brain, so they're going to impair cognition when combined with alcohol on their own. And again, just because a patient is on an antidepressant or a benzodiazepine, that kind of thing, doesn't mean that they can never safely drive again. It means that we need to see how they are responding to the medication before they are considered safe to drive. So stimulants, so the complete opposite of all these downers that we're talking about, things like alcohol depressant or opiates that are depressant or benzodiazepines that are depressant on the nervous system. The classic stimulant is cocaine. So things like cocaine and amphetamines, they rev everything up. So heart rate's up, blood pressure's up, mood is elevated, nervous system is going crazy. So there's some change in perception, there's change in motor function and sensorial changes all around. And they are typically detectable on a tox screen, although the amphetamine screen, like I mentioned, is kind of iffy. There's inconsistent results in terms of the safety of using amphetamines and then performance impairment. One would think, well, is a patient even more alert now that they're using a stimulant? From a scientific standpoint, yes. But you don't want to be overly alert, if you get what I mean. To be using something like cocaine and driving is definitely potentially disastrous. And then, are levels useful? No. Muscle relaxants, things like, and I use brand names here because I think that's what people are more familiar with rather than generic names. Things like Flexeril or Soma or Zanaflex, they all relax muscle tone. So, that crick in your neck that you have or that back spasm that you have, they're there to relax those muscles so the pain goes away. But they relax a lot of other things in the body too. So they cause more drowsiness and decrease your alertness as well. And then combined with alcohol, you have that additive effect. Now, some of these can cause false positives. For example, Flexeril can cause a false positive for some antidepressants, depending on the toxicology screen that's used, for example. And the levels of these are not useful. And it varies how long a patient will be having the depressant effects from some of these drugs. Like, for instance, Flexeril is a drug that's taken 3 times a day or prescribed to patients 3 times a day. But the patient can take the drug at bedtime and wake up in the morning and still feel extremely drowsy, even though it took 1 dose. It's a very sedating drug. So those are very concerning when it comes to driving. Cold medications. So cold medications are a broad category. So things like antihistamines and decongestants. I had a question in my last lecture about Benadryl in particular, so diphenhydramine. So the issue with diphenhydramine in particular in terms of impairment is that studies have shown that, diphenhydramine is supposed to be a short-acting antihistamine, and it's used for allergies, it's used for sleep, it's used for skin reactions, and it's supposed to be taken every 4 hours. I think, okay, it's pretty short-acting. But for some people, adults, for adults that take Benadryl at bedtime, they wake up in the morning, they feel fine, they slept well, they get out and drive. They don't realize that Benadryl has this kind of secret hangover effect, for lack of a better term. In other words, it can impair cognition and judgment while driving, and you don't even know it. So there's been studies that show that actually taking Benadryl for sleep can impair driving the next day, and the driver could not even know that. So this is a broad category, and some can cause more drowsiness than others, and certainly those drugs that cause drowsiness intensify the effects of alcohol and make someone more drowsy and affect their ability to drive. Some of these cold medications can show up as false positives for amphetamines, as I gave my example of taking the Sudafed last night, and levels of these are not useful. So now moving on to some common illegal drugs. So cannabis, which is another name for marijuana, is generally the most common drug that's detected in accident-involved drivers. And it'd be interesting, now that we have medical marijuana legal in Pennsylvania, to see how the state of Pennsylvania will change what the threshold is for considering a client impaired with THC. Right now the level is 0.1 nanograms per milliliter, and I'm not really sure how they came up with that level, because they might as well just say they have a zero tolerance, because if somebody has a given level of what they're measuring for marijuana is THC, that doesn't tell us if they used it an hour ago or they used it 2 weeks ago. So were they actually driving impaired or not? But having a cutoff like that is saying, we don't want to get into the maybe or maybe yes, maybe no. We're just saying this is going to be the cutoff, and even if it was 2 weeks ago, they have a level, they're considered impaired. So what are the effects of THC? Well, it's going to vary with people who are using regularly versus not using regularly, or how much they smoked, or how potent the particular batch of marijuana was. But there's definitely the altered perception, which is concerning for people that are driving after using marijuana. And, there's definitely that euphoria. Some patients have some visual disturbances or weakness, and, police officers are looking for bloodshot eyes, but that could be for 60 other different things. And so the metabolites that we're looking for, in particular THC for marijuana use, can be detected several days after one-time exposure, or even weeks, usually up to 30 days though, after a chronic exposure, meaning time and time again. And so there's an additive effect when alcohol and marijuana are used in combination, so that's a dangerous combination. And I've gotten a question about hemp seed. So you get hemp seed in like a Whole Food store or a health food store, that kind of thing. So, that can sometimes cause a false positive, although less likely for hemp seed to do that nowadays with the different assays that are developed. On to cocaine. So again, cocaine, I said there are no false positives for cocaine. One of my previous lectures, I got the question of if one sexual partner is using cocaine and the other one is not, can the one who's not come up positive cocaine because of the sexual partner? And that was an interesting question. I did some research on that one because I didn't want to answer just like that. The answer, long and short of it, was no. There certainly is transfer of cocaine in different body fluids, but again, not enough to trip a drug screen. And finally, heroin. Heroin is an opioid, slows everything down. And not only is it something that slows down the nervous system, but it slows down the gastrointestinal system. So for those of you that may have heard about the word on the street about the over-the-counter drug Imodium being used by those who are interested in getting high off opiates but can't either afford or get things like heroin, and they're using Imodium, which is an anti-diarrheal drug, it's related to the opioid family, and if you take enough of it, not only does it slow down enough so your diarrhea stops, but it also, we're talking like, 20 boxes of Imodium, not just a few tablets, but it also gives you the same high as heroin. So if you see somebody coming out of the local pharmacy, you know, with bag after bag of Imodium, you know what they're up to. So I wanted to do some case examples. These were actual cases that I was consulted on. I tried to, you know, keep it to a line here or a line there, just to give you the gist of it. So this is a 52-year-old man who was injured while on the job. His initial toxicology screen for THC was positive. So that's all it says, positive or negative, positive, negative. He was positive for THC. Now then it says next to it, the cutoff value was 50 nanograms per milliliter. So what does the cutoff value tell me? Well, if he was 49 nanograms per ml, now I don't have a number on him. I just have the screening results at this point. So just positive or negative. If he was 49 nanograms per ml, he would have come up negative. Okay, because that's your cutoff, that's your threshold for tripping the toxicology screen. The confirmatory testing that was done, so he had mass spectrometry done, that's via blood, was 204 nanograms per milliliter. And the cutoff for that particular test was 15. So they can only measure to a certain amount, and they could not measure below 15. That's all that means. Now, there's a couple questions surrounding the results of this case. So, first of all, why were they testing this man for drugs? Well, they wanted to know, was he high while he was on the job? That's what the big question was. Was he injured because he was high? Or was he injured for some other reason that was the responsibility of, you know, the workplace for keeping him safe? So that was the whole question. So as a toxicologist, that's what they asked me. Was he high at the time? Well, there's a few interesting things. The first question that I was asked was, wow, the cutoff is 15 nanograms per ml, and he's 204. He's sky high. I said, all right, well, let's take a step back and I'll explain to you what cutoff means. Cutoff does not mean that, you know, if he's 15 nanograms per ml, you know, if he's close to that, then he's not high. If he's far from that, he is high. It has nothing to do with it. It just means how low the screening can, or how low the test can detect. So the result of 204 nanograms per ml tells me one thing and one thing only, that this 52-year-old man used marijuana at some point in time. And it was interesting. I do not have the wrap-up of this case, unfortunately. It's not something that went to trial. It was an occupational case. So it was interesting because it was me and it was two physicians that were consulted as experts on this case, and I got to see what their expert report said. So the two physicians, they were not toxicologists, but they are very knowledgeable physicians. Their report said this man was high and impaired while on the job because this level of 204 nanograms per ml tells us so. Okay, so that's something that I don't know. So I put in my report, I said, look, I referenced this reference, that reference, the other reference, not tie that level to what his level of impairment was, if he was high at the time. All it tells me is that one single thing, that this man used marijuana at some point in time. Now, how this could have played out is if, and they did not have this, if they had, you know, his coworkers saying, oh, you know, he was acting very bizarre that day, and he had bloodshot eyes, and, you know, he was off balance, and, you know, had all these symptoms, then I can say, well, you know what, based on the symptoms, and he had a level, now that's telling me it might have been more recent than we know. Do we know the hour he used it? No. So you kind of don't look at the level in isolation. This case is a 44-year-old man who was stopped for expired registration, and then he failed the field sobriety test. So we didn't have anything in terms of observations related to the man's appearance or demeanor or physical function, other than, of course, the failing of the sobriety test. So he has two toxicology tests of interest. He has a blood alcohol concentration of 0.05, so he's below the legal limit on that. And then he has this, you're going to see this a lot of times, the benzoyl ecodine level, and that's the metabolite for cocaine that's being measured. So this gentleman's saying, now again, of course, there's no tolerance for Schedule I drugs while driving, but he's saying, I didn't use cocaine and drive. I used cocaine the day before. So the question was, is that true or not? And really can't say. We have no way to say that he used it recently or he used it yesterday. We don't know what his dose is. So it wasn't able to, we weren't able to determine, yes, he was high on cocaine or he wasn't high on cocaine at the time. So I want want to just take some questions. We have a few minutes left. I always leave, 10 minutes for questions. And, if you have a case that you want to go over, I do this, we call this in the hospital the curbside consult, which means, just like a very high-level overview of a particular case that you may have that you think may, need a toxicologist, but you're not sure of the viability. I'm happy to do that. So you have my contact information if you have like a complex question or want to ask about a specific case. But if there's any principles or any questions about what I went over today, raise your hand. I would love to entertain your question and share the answer with your colleagues. Yes, sir.
Just a quick question on the drug screen, say for marijuana. You have a cutoff value of 50. Is that a standard cutoff, or can an employer manipulate that? We're going to use a cutoff of 30 or 40, and force somebody into a positive range based on that test.
It's a good question. It's not up to the employer. It's more of from a scientific standpoint that the folks that are doing the lab testing have a particular cutoff. And there's also regulations from a federal level to say this is what's considered a cutoff for the workplace type thing. So the individual employers are not involved in that at all. That's a great question. Yes?
Yeah, with regard to Pennsylvania and their recent passage legalizing marijuana, how are they going to determine what viable number is?
I can't wait to see, because I don't know how they're going to do that. Now, there's other states that have had this for a long time, and they may adopt what other states have done. Colorado has a number, but again, if you can't tie a number to level of impairment, how are you as a state going to determine what's a safe level to drive? I find that very interesting from a toxicology standpoint. I don't know, because patients are using medical marijuana can't be told you can't drive, you're not legal to drive, because they're taking a legal drug for medical purposes. So I see you were listening carefully to my talk, because that's a very good question. Yes?
I've heard anecdotally that marijuana use in juveniles can trigger psychosis. Have you heard of any?
I've read about it.
Is there literature on that?
There is literature on that, and if you're telling your teenage son or daughter all the reasons not to use marijuana, that certainly is one of them. But yeah, that is in the medical literature. There's also, for the different amphetamines, the designer amphetamines, those also are in the literature as potentially causing psychosis as well, like your MDMA or ecstasy type thing. Any other questions? Yes.
With blood testing in an employment situation, is there a standard protocol so that if they test positive within the employer, the Department of Transportation limits, and then say it can't be, I want to retest, what's the time frame? Are there any standard procedures recognized in the industry where you can do it and you can't do it?
That I don't know, because they don't contact me till after they get the results, so I don't know what's allowed in terms of retest or time frame. But that would be something of interest of me for sure, but I do not know the answer to that. Yes?
Is there a resource that, somebody comes into your office and you get a report and these are the numbers? Is there a place you can go to look to see what those numbers mean, or do you have to only call an expert?
Well, that's a good question as well. Okay, so you're going to get that report and you'll see what's considered this very misleading at times. On that report, it'll say normal levels or therapeutic levels, and it's a little bit difficult how to interpret that. I mean, there's certainly literature on that, but it's in the scientific realm, so it's a little bit hard to interpret. Sometimes you can speak to one of the physicians at the laboratory to help you with that, or you need to call an expert. But if you have a laboratory that you're able to reach one of the medical directors there, it'll be a physician, then you'll be able to get your answer that way too. There's no more questions. I'm going to let everybody go to dinner. Enjoy your night, and thank you for your attention.